All right, class, let's talk about our last respiratory disease, pneumonia. Pneumonia is typically going to be characterized by an anatomical diagnosis as opposed to a pathological diagnosis. Pneumonia is an inflammatory condition within the lungs or pleural cavity, and where we have the alveoli, the small pockets that we have gas exchange occurring, where we have a respiratory membrane, where those alveoli fill with fluid. After those alveoli fill with fluid, the fluid can then become a breeding ground for bacterium. A very wide variety of microorganisms will be able to reproduce within that fluid and cause pneumonia. Generally speaking, those microorganisms have characteristics that allow them to live in the lower respiratory tract, avoid phagocytosis, and avoid being killed, or I should say, avoid being killed once they're inside some of the phagocytes. If we look at what demographic is most hard hit by pneumonia, it's definitely going to be the children. Children are harder hit, and more children die from pneumonia than any other disease. Within the United States itself, we have 2 to 3 million cases, 2 to 3 million cases every year of pneumonia, and of those, there's typically about 45,000 deaths from pneumonia. There's a couple different ways we can acquire pneumonia. We could have Streptococcus pneumoniae. This is going to be about 40% of all bacterial cases. We could have Legionella pneumoniae, Haemophilus influenzae pneumoniae, Mycoplasma pneumoniae, and Chlamydophila pneumoniae. Histoplasma capsulum is a fungus-based pneumonia, and we also could have Hantavirus-based pneumoniae. Most of these, though, are going to be bacterial in origins. HIV vaccine has reduced the incidence of the Haemophilus influenzae. Legionella influenzae is very uncommon. Mycoplasma pneumonia and Chlamydophila pneumonia, or walking pneumonia, is fairly common. Hantavirus is less common. If we look at Streptococcus pneumoniae, one of the single most common forms of pneumonia, it's sometimes referred to as pneumonococcus. These are tiny little bacteria. They're small, gram-positive, and have a flattened coccus shape or geometry. They oftentimes are going to appear in pairs, even though they're referred to as a streptococcus and not a diplococcus. These bacterium are capable of causing disease in individuals that have old age, or if it's winter time, generally speaking, that aids these bacterium, or if there's an underlying viral-based respiratory disease, if the patient is diabetic, or if there's chronic abuse of alcohol or narcotics. Individuals that are at risk are encouraged to be vaccinated with PPS-V23, which is a vaccine against this particular strain of bacteria and helps reduce the pathogenicity of slightly different strains of the same kind of bacteria. We also have Legionella pneumophila. This is a bacterium that's weakly gram-negative. It's going to sometimes have a coccus morphology, sometimes it has a filamentous morphology. This bacterium is able to survive and persist in natural habitats. It's going to have a natural reservoir of outside. It's going to be in tap water, cooling towers, spas, ponds, other freshwater sources. When you think Legionella pneumoniae, I want you to think of generally stationary water, or water that's not in constant motion. Legionella pneumophila is resistant to chlorine treatments and can live in association with free-living amoebas that are present within the water supply. Generally speaking, this pathogen is going to be released as an aerosol from the formation, is released during aerosol formation. So as the water is misted, the pathogen will be carried with the mist at long distance, depending on the size of the aerosol droplets and the size of the speed of the wind. There are some less common pneumonias as well. These atypical or uncommon pneumonias are Mycoplasma and Chlamydophila pneumonia. These kinds of pneumonia are transmitted by aerosol droplets, just like the Legionella pneumonia is. However, these kinds of pneumonia are typically going to be confined to individuals that live in close proximity or close quarters to each other. So think of a family unit, a military barracks, or a dormitory situation. This is referred to, or this can be, another atypical pneumonia is also walking pneumonia. Sometimes these mycoplasmas are referred to as walking pneumonia. And this is called walking pneumonia because the patient has a full-blown infection, but they have almost none of the typical signs and symptoms associated with the full-blown infection. If you have to get pneumonia, this is the kind of pneumonia that you want to get. Kind of like if you had to stay home from school when you were younger, you wanted to get conjunctivitis because you still felt fine, but hey, you had to stay home from school. We also have the Hantavirus. The Hantavirus is another pathogen that can cause community-acquired pneumonia. In 1993, there was a cluster of unusual cases of very severe lung edema, and this was in young, healthy adults in the Four Corners area. It was found to be caused by the Hantavirus. This virus is categorized within the Buniviridae family. It's an enveloped virus, so it's going to have phospholipids on the outside with a protein-based capsid interior to that or deep to that. This Hantavirus is going to be associated with mice in proximity to humans. So when you think of mice being near humans, I want you to connect that to the Hantavirus. As the mice urinate and as they defecate, their excrement can become aerosolized, and that aerosolized excrement from the mice can then infect human beings. There was a secondary outbreak or localized outbreak that occurred of Hantavirus in in Yosemite. How to get New York out of that? Sorry, guys. In Yosemite, and that occurred within the year 2012. So when we think Hantavirus, though, I want you to connect that to mice, feces, and humans breathing that in. Another pathogen is Histoplasma capsulatum. This pathogen is endemically distributed on every continent except for Australia. So it's everywhere except for Australia. We should probably also include in there Antarctica as well. That's kind of the forgotten continent in terms of microbiology. There's going to be very high incidence of this pathogen, though, in the east and central regions of the United States. This pathogen needs moisture, so it grows really well in moisture soil that has lots of nitrogen, lots of nutrients in it, particularly soil that has lots of guano or bird droppings in it. So if we were to go spelunking, for example, in a cave that has bats, that guano or bat poop that's on the floor of the cave would be an ideal location for Histoplasma capsulatum to grow. This pathogen is very widespread, and its distribution is measured by injecting a fungal extract under the skin to see how strong our response is to it. Another form of walking pneumonia is Mamunosite girovesi, or formerly known as Carnini. This was discovered in 1909. This is an agent that can form pneumocystis pneumonia. This kind of pneumonia is an opportunistic infection associated with HIV/AIDS patients. It's typically going to be transmitted through the inhalation of the fungal spores. Traditional antifungal drugs are not necessarily effective against pneumocystis pneumonia, typically because the makeup of the organism's cell wall is not your typical typical chitin polypeptide. Community-acquired pneumonia can also be acquired through respiratory viruses. There are a great many number of respiratory viruses that can cause community-acquired pneumonia. One thing that all these viruses have in common is that they can live in upper and or lower respiratory tracts. They can get into our upper respiratory tract through our daily activities, and they are also part of the normal microbiome, or normal biota, I should say, of our upper respiratory tract. After these pathogens, these viruses make it into our lower respiratory tract, they can initiate the state of pneumonia where alveoli start to fill up with fluid. Viral-based pneumonia, though, generally speaking, is going to be pretty mild. When we think of fungal and bacterial and protozoal-based pneumonias, those are going to be much more profound. So wow, There's a lot of ways to get pneumonia. The single most common way to get pneumonia is Streptococcus pneumoniae. I want you to connect Streptococcus pneumoniae with pneumonia. There are also fungal sources. There are also viral sources, and we have some protozoal sources as well that can cause pneumonia. We also have healthcare-associated pneumonia. Unlike community-acquired pneumonia, healthcare-associated pneumonia is a nosocomial infection. It's an infection that's associated with being in a hospital. Approximately 1% of the people that go into a hospital experience this kind of pneumonia. The mortality rate of healthcare-associated pneumonia is quite high, 30 to 50%. And the most frequent causes of healthcare-associated pneumonia are Pseudomonas aeruginosa, Acinetobacter baumannii, Streptococcus pneumoniae, Klebsiella pneumoniae, Staphylococcus aureus, and HAP caused by MRSA. And then there are several polymicrobial forms of healthcare-associated pneumonia. The abnormal breathing and aspiration of the normal respiratory tract that can oftentimes occur within a clinical or hospital setting can allow for these pathogens to enter into the lungs. Mechanical ventilation of a patient will oftentimes push these microorganisms from the upper respiratory tract to the lower respiratory tract as that tube is inserted through the trachea. To culture and diagnose this kind of pneumonia in a patient, we're going to need to collect a sputum sample and a tracheal swab, but they aren't entirely useful. Other times, we should look at the endotracheal tube for bronchoalveolar lavage culture. So instead of getting a swab from the upper respiratory tract, we should try to collect a sample from the lower respiratory tract. That upper respiratory sample can be collected, but it's not terribly useful. Patients that are already on some kind of antibiotic regimen may already have some kind of effect on the results of the test, so that should be compensated for as well during the culture and diagnosis, because many patients in hospitals are already going to be on some kind of antibiotic regimen. If we look at the prevention and treatment of healthcare-associated pneumonia, we need to take the patient's heads and elevate them to a 45-degree angle. This helps to reduce the amount of sputum that goes back down into their windpipe. We need to have preoperative education for patients. This preoperative education emphasizes deep breathing, frequent coughing, and this can reduce the amount of postoperative infections of healthcare-associated pneumonia. In other words, after surgery, make sure to breathe deep and spit all the sputum out of your mouth. You don't have to breathe it back in or swallow it. If there's a mechanical ventilator in use, we need a proper care and sterilization to keep that equipment sanitary. And then empiric therapy should begin as soon as we notice that there's some kind of hospital or healthcare-associated pneumonia that's suspected. And we should proceed down a standardized path of treatment until we can come up with a more precise diagnosis for that disease. So here we have our summary figure for healthcare-associated pneumonia. Healthcare-associated pneumonia can be caused by a wide variety of bacteria from the upper respiratory tract, the stomach, or some environmental contamination on our respirators. The most reliable method for diagnosing is to culture fluid from the lower respiratory tract, and the most common treatment is a broad-spectrum antibiotic. Here is a summary figure showing the pathogens that we talked about and a few that we didn't. If you have any questions for me about this material, please feel free to post them in the class discussion boards or shoot me an email. Happy study!